Warm wishes of Women's Day celebration to all the participants of this conference. And welcome to this today's topic on Stabilize and Smile, Denture Conference Explored. I am Dr. Annie Susan Thomas, Professor and Head, Department of Prosthodontics, Annoor Dental College. Tooth loss leads to poor functional capacity as well as nutritional, aesthetic, and psychological challenges such as lowered self esteem and poor social integration. Negative changes on the facial appearance are often perceived by the persons affected as well as those around them as negative changes to the individuals themselves. Therefore, when we treat dangerous patients, we are managing not just their oral biomechanics, but more importantly, their individuality. Success demands not only the technical expertise, but also empathy with the person's fears and aspirations. As you can see in this picture, the vertical, as the teeth are lost, the vertical dimension is lost. The patient also lacks the where to bite, and there is formation of angular cheilitis. All this affects the patient's life adversely. And WHO Global Oral Health Status Report that was was taken in 2022, they say that estimated global average prevalence of complete tooth loss is about 7% among people aged 20 years or older, and for people aged 60 years or older, as much global prevalence of 23% has been estimated. So it is a very large number as we calculate it. And as at the end of the day, as women practitioners, we want to be happy and also our patients to be satisfied. And we should be able to enable and motivate better the patient for the better treatment options for more stable treatment outcomes. And a systematic review and meta-analysis on socio-demographic determinants of edentism in the elderly population. They say that women are more likely to develop edentism compared to men. And in this picture, you can see that characteristic facial and circumoral changes associated with a dentate young woman in her 20s. And parts A to D are in stark contrast with those who observed in an aging woman who has been wearing denture for several decades. The dentures has three surfaces, as you all know, that is fitting, polished, and occlusal. And these are established separately by the dentist. They were integrated to replace the missing teeth and severely reduced supporting tissues as an integral part of routine prosthodontic protocol. Optimal aesthetic support combined with the adequate renewed function usually can be achieved for most edentalous patients with complete dentures. So we can just go through the consequences of complete edentism: continued bone loss, negative soft tissue effects, negative facial aesthetics, decreased masticatory performance, and diet-related health effects and psychological impact. And in 1963, Atwood described 6 different stages of bone loss in the anterior mandible after the loss of tooth. As you can see here, there is tooth, and the bone is preserved here. As the tooth is lost and then the bone resorption starts, at last, the basal bone is the one that remains. And 4% strain on bone is needed to maintain the resorption formation. When pressure is applied to the tooth by means of tooth to the basal bone, it is preserved actually. On tooth loss, this is resorption starts like anything. Within first year of extraction for immediate dentures, 30% reduction in width and 4 millimeter reduction in bone height occurs, and the mandibular bone loss is 4 times more than that of the maxillary bone loss. And you can see here that the teeth are preserved. When the areas where teeth are preserved, the bone is preserved. So that this is a contrast between the alveolar bone sustained by a healthy periodontal ligament and the resorption vulnerable residual ridges that have been periodontally deprived for several years. And here you can see what are the soft tissue consequences that are happening to as a result of bone or teeth loss. It's attached keratinized mucosa decreases, high muscle attachment or near the crust, and enlarged tongue occurs, and thin covering mucosa prone to resorption, abrasion by resorption. And soft tissue consequences of bone loss often include the attachment. The attachments are moved towards the crust of the residual ridge, making our impression and the stability of our dentures affected. And you also know that the masticatory function also decreases dramatically. Only 1/6 of the masticatory load is only 1/6 of the dentate per patient. And we have to be very careful in each step of denture fabrication to make our denture stable. So in the primary impression, you should be very confident that it covers all the denture bearing areas to the full extent. If there is an inadequacy or it lacks a positive tissue contact, that can lead to an inaccurate secondary impression. You cannot get a good secondary impression without a good primary impression. If you think that there is some inadequacy, you have to redo the primary impression, and that thereby ensuring the denture stability. And you all know, you have noticed that this functional sulcus is only half that of the anatomical sulcus. So your tray should extend only up to the just 1 millimeter below the functional sulcus, so that we can capture the muscle attachments, the frenulal attachments in a functional manner. Otherwise, during function, the denture will be unstable. And the secondary impression, we always need a wash impression. As a thin layer of secondary impression material should be there. Only a thin layer. If it is more, that can result in an overextended denture, the hampering our denture stability. So there are special conditions in which if there is a long-standing injurisness, you can see flabby ridge. You may come across flabby ridge. In that, you have to modify your technique a little bit, so that after completing the final impression, then you have to cut a window in the area of flabby ridge, and then it has to be the impression should be in that area should be with a mucostatic impression material. That is you can inject line body and get a mucostatic impression in that area. If you record that flabby ridge in a compressed manner, what is happening is that it is under compression. So it will rebound. This elastic tissue will rebound, and that can hamper the denture stability. So it should be in a non-compressed form. So we have modified the technique like this, window technique. And when there is a very resorbed ridges, you can go for all green technique, or you can go for admixed technique. In this, a low fusing impression compound is added, and in an incremental manner. And then after that, we do a lining with the light body. And a mucocompressive impression can also be is advisable in the case of extreme residual resorption. And it should be a wash impression. You should see it is only a very thin layer, so that you can see the border material through the impression. That much thin layer is only needed for the secondary impression. As you can see here, in the jaw relation, you have to be very careful that it should be in the appropriate vertical dimension, and also it should be in the correct centric relation. And the relation of the mandibular occlusal plane should be within the lower lip. If it is more than that, that itself can cause denture instability. So you should be very careful that occlusal plane should be within the lower lip. And this is another beautiful technique which can be utilized for denture fabrication. It is a neutral zone technique. What is it? It is there's a zone. This is called the neutral zone. This is the area where the pressure in the by the cheek and also by the tongue are get neutralized. You have to arrange your teeth in the neutral zone so that it will not be affected by the pressures of the tongue or cheek. So it will be stable when they act. Okay. And this is another thing you have to remember is that we have to keep the tongue in a, there should be concave areas on the lingual side and also on the buccal side so that the tongue can rest properly on the lingual borders of the lower lingual surfaces of the lower denture, and also in the buccal area the buccinator should be able to cheek muscles should be able to properly, it should be seated properly so that during function, it will have it will not dislodge our denture. And during trial, if we are doing using permanent denture bases, and also, so you can test retention, stability, and everything of the denture during the trial. And you should say that you should insist that the patient should be very, very clear about their teeth positions. Everything should be cleared in this particular step. Otherwise, the patient will blame you for not having the teeth arrangement that was desired by the patient. So everything should be cleared in this step, because after fabrication, you cannot alter any of the teeth arrangements. And you can give characterization to your denture like this. You can mimic your the papilla, all the mucosa, everything can be mimicked in the denture so that the patient will feel that it is their original teeth. And you can even label the denture with their name or any number so that it is personalized to the patient. And this is saliva reservoir denture. Here you can see that a saliva reservoir is attached to the palatal region of the upper denture so that it can release this artificial saliva at a controlled rate. It's extremely important for a xerostomic patient. And this is the hollow denture. Here you can see that the denture is made hollow so that in the severely resorbed cases, if the maxillary denture is having much weight, it will hamper our denture stability. So, and retention of the denture. And this can be managed by giving hollow denture to this type of patients. And internally weighted denture can also be given to the lower denture, can be given in the case of the lower denture with residual resorption. Here, the metal framework is actually fabricated so that it will have some weight, so that with the help of gravity, it can stay there. So this is a Kusil denture, and here, if the patient does not want to extract the teeth, and there are two remaining teeth or few remaining teeth are there, you can make a Kusil denture. Here, there is an elastic module is inside the denture around the tooth, so it will give some support to the existing denture. And this is a metal-based denture. This is extremely useful in the case of a single complete denture, where the opposing tooth is natural. Opposing dentition is a natural tooth. It will cause immense pressure on the denture. So the frequent complaint of this type of patients is the frequent it is broken. The opposing denture is broken. So frequently. So in that case, you can use this metal-based denture. It is extremely helpful in those cases of patients. And this is a liquid supported denture. Here you can see that a soft liner can be applied to the internal surface in the extremely resorbed ridges. This is very useful. And if the patient is having limited mouth opening, we can also fabricate sectional complete denture. Here, the denture can be introduced in the mouth sectionally, so that the patient and then it is stabilized in the mouth by means of some internal stabilizing mechanism. So it is also extremely useful, and the patient should be able to chew their food confidently with a stable complete denture. And even a well fabricated denture will not be satisfied by the patient if you do not give postoperative instructions properly. You should ask the patient to chew bilaterally. Also, you have to say the patient that it will take 1 or 2 months to adjust to it, so that the patient can be mentally accustomed to your denture, newly given denture. And it is Dr. George A. Sarb, the notion of implant supported overdentures in JPD 1998. He said that whenever possible, it should be a tooth supported overdenture. When few teeth are remaining in the mouth, it should be used to make a denture, overdenture, so that the denture will be stable. And Brandmark's original prosthodontic protocol was screw retained full arched fixed prosthodontics. Here, he wanted to have a processes to the patient, attached to the patient, which is only electively removable. And this is a two-supported overdenture. If the intra-space is enough, you can give ball attachment to the tooth coping, metal coping, which is fixed on the, cemented on the prepared tooth. If there is not much intra-space, you can even give only the metal coping, and over that the denture is placed, fabricated, so it will be stable in the patient's mouth. And this is the telescopic denture. If few teeth are remaining, even if it is grade 1 mobility, you can keep this teeth, and on the teeth there is primary coping, and in the denture there is secondary coping. So the important factor is that there is no palate for this telescopic denture. The frictional fit between the primary coping and the secondary coping is actually the that gives retention to the denture, and it is extremely stable in the mouth. In night, at times they can remove the denture, and you can do all the oral hygiene measures for the remaining teeth. And it is an excellent denture for this type of patients. And you can see that after the teeth are lost, the how does this resorption act affects, and this thin mandibular ridge can cause bucket handle fracture actually. But if you give a overdenture by tooth supported or implant supported, it can preserve the bone like anything. It's an example of an implant supported overdenture. Here you can see that after placing implants, there's the ball attachment is attached to the implant, and over that this denture is placed, and it is extremely stable in the patient's mouth. And this is an example of implant supported fixed processes. Here in the maxilla or mandible, 6 to 8 implants are placed. And over that, a fixed process, this is screw retained fixed processes, can be placed so that it is just like the patient will feel that it is just like the natural teeth. This is a very good option for these irregular patients. And I hope you know all the details how to make your from this presentation. You must have got all the details how to make your denture stable. And thank you very much for your patient listening. Thank you.